Medical students spend years memorizing anatomy and passing written exams. But the moment they step into a clinical environment, they face a severe gap between knowing the theory of a life-saving procedure and executing it correctly under intense pressure. This flow chart maps the standard medical learning curve. Students move from reading textbooks to passively observing veteran doctors. But the entire system hits a hard bottleneck at the clinical stage, where actual hands-on repetition with real patients is severely limited. The reason for that bottleneck is simple. You cannot hand a scalpel to a novice and ask them to practice a complex, high-risk procedure on a living person. The ethical constraints mean students simply do not get the sheer volume of physical repetition required to master complex surgeries before their residency. That limitation is forcing a shift in how institutions train their staff. Medicine is moving away from flat 2D CT scans and into a programmable world. This animation shows exactly what that looks like. A standard 2D cross-section expanding into a fully rotatable, interactive 3D holographic space. But bringing extended reality into hospitals isn't as simple as buying a few headsets. We have to weigh the heavy logistical friction and steep financial costs of adopting this technology directly against the concrete clinical outcomes it produces for both patients and practitioners. When we map those trade-offs, a clear picture emerges. Continuing to rely on traditional 2D training methods to prepare doctors for a 3D, high-stakes medical reality carries a liability that is no longer acceptable. Inside the operating room, anatomical surprises dictate survival rates. If a surgeon opens a patient and finds a tumor wrapped around a blood vessel in an unexpected way, the risk of a fatal complication spikes immediately. This split-screen comparison weighs the friction of augmented reality against traditional surgery. By wearing AR visors, surgeons can superimpose an AI-segmented 3D hologram directly onto the patient's physical body in real time. The result is essentially a 3D GPS for the human body. Before making a single incision, the surgical team can look entirely through the patient's tissue to map exact blood vessel locations and tumor depths. That capability translates to direct survival outcomes. By completely mapping the anatomy beforehand, specialists are successfully removing liver cancers that were previously classified as untreatable. It is also allowing doctors to guide radiation-free microwave ablation tools directly into lung tumors with pinpoint accuracy. The friction here is entirely workflow-based. It requires extensive preoperative time to run patient scans through the AI software to generate the holograms. Furthermore, surgeons have to physically adapt to wearing a visor for the duration of a multi-hour procedure. Those are real logistical hurdles. But when you weigh that preoperative preparation against the ability to completely eliminate anatomical surprises from a complex surgery, the friction is a very small price to pay. Nursing programs face a different challenge. A real hospital ward is loud, chaotic, and completely unpredictable, the exact opposite of the quiet, controlled classrooms where most nurses learn their theory. To bridge that gap, institutions are building virtual hospital wards. Instead of treating one plastic dummy at a time, nursing students put on a VR headset and step into a fully simulated multi-patient environment. This image shows a first-person interface inside one of these virtual wards. The software actively forces the student to manage deliberate distractions, sudden drops in vital signs, and overlapping demands from multiple patients simultaneously. This targets the exact cognitive skills that usually take years to build on the floor. Students practice rapid triage prioritization. They also perform high-risk psychomotor tasks, like an infant lumbar puncture, learning the precise physical pressure required, all with absolutely zero risk to human life. This split-screen comparison highlights the institutional trade-offs. Building a VR infrastructure requires significant initial capital. Administrators also have to manage the fact that a percentage of users will experience simulator sickness and need alternative accommodations. But the math still works out in favor of the technology. The high institutional cost of setting up the hardware is heavily outweighed by the ability to mass-produce clinical judgment and strip away real-world patient liability. The primary barrier keeping this technology out of medical schools actually has nothing to do with the headset. The real friction is administrative. Trying to stitch together a dozen disjointed VR apps into a rigid, accredited medical curriculum is a nightmare for faculty. This product profile slide for Medverse, developed by Karunji Infotech, shows how the industry is solving this. Instead of fragmented apps, we provide a turnkey, centralized library of integrated curriculum tailored specifically for first-year medical students. This module list shows exactly how broad that coverage gets. It spans 10 critical bodily systems, from the cardiovascular to the central nervous system, ensuring the software maps to the entire human body rather than just a single isolated specialty. This feature list highlights why this matters to accreditation boards. The interactive anatomy dissection labs adhere strictly to competency-based medical education frameworks, providing the student with instant, objective feedback on their performance. This deployment slide explains the physical rollout. It requires dedicating a lab space for 8 to 10 headsets, but it comes with a centralized software application that allows faculty to directly monitor, track, and report on student usage metrics. Piecemeal software creates administrative dead ends. Scalability and actual return on investment only happen when institutions invest in comprehensive, curriculum-mapped ecosystem deployments. Relying purely on passive observation to train the next generation of medical professionals is no longer a defensible standard of care. Spatial computing and immersive repetition are becoming mandatory clinical competencies. This 4-quadrant matrix maps where each immersive technology belongs inside a healthcare institution, based entirely on the required effort versus the clinical impact. For surgeons and specialists, augmented reality holographic overlays sit squarely in the top left quadrant. It requires high individual workflow adaptation, but it is an essential tool for executing complex, minimally invasive procedures without error. For nursing programs, multi-patient VR simulation lands in the bottom left quadrant. It is an educational tool focused on individual competency, and it remains the only scalable way to safely subject students to the chaotic reality of a hospital ward. For institutional administrators, the focus shifts to the bottom right quadrant. Educational tools built for systemic deployment. This is where piecemeal app investments fail and comprehensive platforms prove their worth. The turnkey model provided by Karunji Infotech occupies this exact space. By bundling the hardware, the CBME-aligned software, and the analytics tracking into a single institutional asset, we remove the friction of adoption. Integrating immersive technology requires upfront funding and workflow adjustment. But that initial friction is the necessary price for a system where medical practitioners accelerate their expertise safely and patients survive conditions we once thought were untreatable.